Good day, doctors, and welcome to our module in internal medicine. I will be giving you a quick summary of the pertinent must-knows from chapter 440 of Harrison's Internal Principles of Internal Medicine, 20th edition. This is the chapter on myasthenia gravis and other diseases of the neuromuscular junction. This is the brief outline of our talk. So I will talk about myasthenia gravis and Lambert-Eaton myasthenic syndrome, or what we commonly call LEMS. So let's start the ball rolling and talk about myasthenia gravis. Now, the word myasthenia gravis actually comes from the Greek word myo, meaning muscle, and asthenia, which means weakness, and gravis, which means severe. So severe muscle weakness. Now, myasthenia gravis is a postsynaptic autoimmune disorder. So I want everyone to remember, for examination purposes, that it is postsynaptic. It is a postsynaptic autoimmune disorder, which is caused by autoantibodies. And these autoantibodies are specific for the nicotinic acetylcholine receptor. So another pearl to bring with you to the exam is the nicotinic acetylcholine receptor. So I would like to clarify, it is nicotinic, not muscarinic acetylcholine receptor. So myasthenia gravis is a postsynaptic autoimmune disorder caused by antibodies against the nicotinic acetylcholine receptor. Now, what happens is the antibodies will reduce the number of acetylcholine receptors, thereby impairing or slowing down the transmission of signals along the neuromuscular junction. And myasthenia gravis is characterized by, number one, weakness, and number two, fatigability of the muscles. So again, weakness and fatigability of the muscles. Now, myasthenia is actually not rare. It has a prevalence of about 200 per 100,000 population. And please remember that myasthenia gravis has a bimodal, okay? It has a bimodal peak, which means it occurs at a young age group, which is usually in females, second to the third decade, and the older males, which is 60 to 70 years old. It is overall more common in females with a 3:2 ratio. Now, for the pathophysiology, we highlighted earlier that it is an autoimmune disorder caused by the presence of anti-acetylcholine receptor antibodies. Now, there are three distinct mechanisms that we can outline from the textbook. The first mechanism is accelerated turnover of the acetylcholine receptors at the area of the neuromuscular junction. Second is damage to the postsynaptic membrane. And lastly, blockade of the active site of acetylcholine receptors. So again, what are the three distinct mechanisms? One, accelerated turnover. Two, damage to the postsynaptic membrane. And three, blockade of the active site of the acetylcholine receptor. Now, you have to remember that the presence of anti-acetylcholine receptor antibodies is diagnostic of myasthenia gravis. However, we have to highlight a statement from the book that a negative test, a negative anti-acetylcholine receptor antibody does not exclude the disease. And always remember that the measured levels of the anti-acetylcholine receptor antibody does not correspond well with the severity of myasthenia gravis. Now, there are other antibodies involved in the pathophysiology of this disease. One is the anti-MuSK or the anti-muscle specific kinase, and the anti-LRP4, which stands for low density lipoprotein receptor related protein 4, and the agrine antibody, as well as anti-striated muscle antibodies. So again, what are the antibodies involved in myasthenia gravis? Number one would be the anti-acetylcholine receptor antibodies, followed by anti-MuSK, anti-LRP4, the agrin antibody, and the anti-striated muscle antibody. Now, in addition to the presence of antibodies, the thymus gland plays an important role in the pathophysiology of myasthenia gravis. So it plays a role in the autoimmune process. Now, the book reports approximately three-fourths or 75% of patients with acetylcholine receptor antibodies have an abnormal thymus gland. And the explanation behind this is the presence of the myeloid cells of the thymus. The presence of these myeloid cells in the thymus actually serve as a source of an autoantigen, which can trigger the autoimmune response. So the most common tumor associated in patients with myasthenia gravis would be a thymoma. Now, we look at this illustration lifted from Harrison's Principles of Internal Medicine. This illustration shows you the normal presynaptic junction. It shows you the normal presynaptic junction. As you can see, there are snare proteins here or docking proteins. Just to name a few: syntaxin, SNAP, synaptobrebin, and synaptotagmin. Now, always remember that this is the neuromuscular junction. These are the voltage gated channels. And always remember that acetylcholine is usually released in quanta. It's released in quantal amounts. Now, in myasthenia gravis, you have to remember the following. Number one, there is a reduced number of the acetylcholine receptors. The postsynaptic folds are flattened. Okay, the postsynaptic folds are flattened, and the synaptic space is widened. So let me repeat that. In myasthenia gravis, there is a reduced number of the acetylcholine receptors. The postsynaptic folds will appear simplified and flattened, and the synaptic space will be widened. Now, take note of this terminology, the presynaptic rundown. So I want everyone to remember this. Okay, please remember this by heart. This is called presynaptic rundown. This is the phenomenon where the amount of acetylcholine released per impulse will normally decline on repeated activity. So the amount of acetylcholine released per impulse will normally decline on repeated activity. This will also help explain why the classic symptoms of myasthenia gravis would be weakness, usually at the end of the day or in the afternoon, because this is the time of the day where the body, the muscles, have undergone repeated physical activity. Now, you have to remember that in a patient with myasthenia, there is a decreased efficiency of the neuromuscular transmission. So there's a decreased efficiency of the neuromuscular transmission. And on top of that, we have the presynaptic rundown. And what happens here is this decreased efficiency of neuromuscular transmission combined with the normal rundown will result to the activation of fewer muscle fibers, hence increasing fatigue or weakness. And this is what we call myasthenic fatigue. This is what we call myasthenic fatigue. So please remember that. And it is this concept, okay? It is this concept of myasthenic fatigue, okay? The concept of myasthenic fatigue, which serves as the basic mechanism that will account for the decremental response that we see on one of the diagnostic tests for myasthenia, and that is the repetitive nerve stimulation, or the RNS, which we commonly call also the Jolly test. So on RNS, there is a decremental response in myasthenia gravis, and this is because of the phenomenon of myasthenic fatigue. Now, let's go to the clinical aspect of myasthenia gravis. The cardinal features of myasthenia gravis are weakness and fatigability. So there is a characteristic distribution of the weakness and the fatigability of myasthenia gravis. So usually in the early stages, the cranial muscles, particularly the eyelid elevators and the extraocular muscles, are usually affected. This will be the basis for the complaints of diplopia or doubling of vision and the presence of the drooping eyelids known as ptosis. Now, in about 85% of patients with myasthenia gravis, so that's pretty high, in about 85% of patients with myasthenia gravis, the weakness will spread to the other facial and bulbar muscles, and the patient will now complain of difficulty in swallowing. The speech will be affected. There'll be weakness of the tongue, leading to dysarthria or a classic dysphonic voice or a mushy quality of the speech. Now, there's also proximal weakness of the extremities. The diaphragm will be affected as well as the neck muscles. And this is very significant because one of the complications of myasthenia gravis is myasthenic crisis, wherein the patient will develop respiratory failure as because of weakness of the major respiratory muscles, particularly the diaphragm as well as the other accessory muscles of respiration. So there's facial weakness leading to a classic snarling expression. There's going to be dysphagia, so there's difficulty in swallowing. The speech will be dysarthric. It will have a mushy quality. There's going to be a nasal timbre, or what we call a nasal twang. There's also going to be bulbar weakness. And always remember, the bulbar weakness is classically more prominent in MuSK antibody positive patients with myasthenia. The deep tendon reflexes are preserved, and this is something that everyone has to memorize. The preservation of the deep tendon reflexes helps rule out a differential diagnosis, which is your GBS or your Guillain-Barré syndrome. And by definition, we call it myasthenia gravis in crisis or myasthenic crisis if the patient develops respiratory failure and ventilatory assistance is now needed. So once the patient is intubated and hooked to a mechanical ventilator, this is now classified as myasthenia gravis in crisis. And take note, it is very difficult to wean a patient off the mechanical ventilator when they have myasthenic crisis. This is a life-threatening emergency. Now, here's a photo of the severe drooping of the eyelids or the ptosis, which is characteristic of myasthenia gravis. So I do hope that none of you are displaying ptosis right now at this point of this little talk. So keep your eyes wide open because we are summarizing the most important pearls from a very long chapter from the mother textbook. So here's one of my actual patients. So this was taken with written and verbal consent. As you can see, this is a female presenting with ptosis of the left eye. Now question, what if you present with a chronic smoker? There's ptosis, there's anhidrosis, and there is meiosis. Ptosis, meiosis, and anhidrosis. What is now your diagnosis? What is this syndrome? Ptosis, meiosis, and anhidrosis. So this is now Horner's syndrome. Okay, the ptosis, the anhidrosis, and the meiosis, classic in Horner syndrome or Pancoast tumor, an apical lung or superior sulcus tumor, so usually associated with lung cancer. Now, I'd like to insert this. This is not found in your Harrison's Principles of Internal Medicine 20th edition, but this is very important. This is what we call the Osserman classification. So Myasthenia Gravis grading scale. So the Osserman classification has 5 categories, 4 classes, class 1, 2, 3, 4, and 5. Now, always remember the class increases or gets higher as the symptoms become worse. So class 1 means any ocular muscle weakness, so it's ocular myasthenia. Class 2 is once there's weakness of other muscles aside from the ocular muscles. 3 is moderate weakness, 4 is severe weakness, and class 5 requires intubation. So the Osserman classification. Now, there's also what we call the thymoma-associated myasthenia gravis, which occurs in about 10 to 15% of patients with myasthenia gravis. The rest of the 85 to 90% would have thymic hyperplasia. So the most common thymic condition in myasthenia is actually thymic hyperplasia. Most common tumor is a thymoma. So the thymomas, because of the presence of the myeloid cells, serving as autoantigens that trigger the immune response, it will alter the T cell composition. Now, many of these patients with thymoma-associated myasthenia gravis would exhibit clinical improvement after they undergo a thymectomy. Now, let's summarize the history. Diplopia, ptosis, dysarthria, dysphagia, difficulty in breathing, weakness of the proximal limbs, fluctuation and fatigue, which means with repeated activity, the fatigue becomes worse. So it's usually worse in the afternoon or the end of the day, and the fatigue should improve with rest. On physical exam, there's the ptosis at rest, weakness of the orbicularis oculi, as well as the oris, difficulty in opening the jaw or chewing meat, so weakness following repeated shoulder abduction. Then we go to the laboratory testing, say the anti-acetylcholine receptor immunoassay, which is present in 85% of patients. The repetitive nerve stimulation, or the RNS, wherein the decrement, take note, the decrement of 10% would be diagnostic. Then there's the other test, the single fiber EMG, which is confirmatory but not specific. So you have the presence of the blocking and the jitters. Then we go to the edrophonium test, also known as the tensilon test. So take note, the edrophonium test. Okay, the edrophonium test is also known as the tensilon test. So let's go to the details of these diagnostics. So for the diagnosis and evaluation of myasthenia gravis, the diagnosis is suspected on the basis of both fatigability and weakness. So the diagnosis is suspected on the basis of weakness and fatigability. So take note of the typical distribution, and there is without loss of reflexes and impairment of sensation. Always remember the preservation of the reflexes. Okay, always remember the preservation of the reflexes. Now, this is mentioned in your textbook, the ice pack test. So if a patient has ptosis, you simply apply ice, okay, simply apply ice or an ice pack. over the ptotic eye, and you should expect improvement of the ptosis if this is because of a neuromuscular junction defect. So the hypothesis behind this test, which can be performed in the bedside and in the clinic, is less depletion of quanta of acetylcholine receptors in the cold and reduced activity of acetylcholinesterase at the neuromuscular junction. So what's the dictum here? Apply cold or ice, there should be improvement of the ptosis. Now, for the diagnostics, we've mentioned the anticholinesterase test, which is edrophonium. We commonly call this tensilon test. This is available in St. Luke's Medical Center in Manila. Then we can do the repetitive nerve stimulation test. This is available in most tertiary hospitals in the locality. So this is the Jolly test, and you'd expect the decremental changes. Then, of course, something very sensitive is the single fiber electromyography, the single fiber EMG, where you look for blocking and abnormal jitters, and the acetylcholine receptor antibody assay. This is very important. So for the repetitive nerve stimulation, you have to remember this is one of the electrodiagnostic tests which are very helpful in evaluating and clinching the diagnosis for myasthenia gravis. Now, there's a tip in the book that if this patient is taking acetylcholinesterase inhibitor drugs, this should be stopped at least 6 to 12 hours before the repetitive nerve stimulation test is performed. And it is best to test the weak muscles or the proximal muscle groups. For example, the facial muscles, orbicularis oculi. Some would stimulate the nasalis. Some would stimulate the risorius. So look for the weak muscles and test the proximal muscle groups. Now, always remember, there's a basis here. There's a discussion in the book that there is a rate of delivery for the electrical stimulation. So this is delivered at a rate of 2 or 3 stimulations per second. That's why they call it repetitive nerve stimulation. And these action potentials are recorded in the computer. And always remember that in normal individuals, the amplitude of the action potentials, which you see on the electrodiagnostic testing, should not change by more than 10%. In patients who have myasthenia, this is what you have to bring with you, and there is going to be a significant rapid reduction of more than 10%. And this is what we commonly call the decremental response. Okay, there's a decrease. So you have to remember this because in myasthenia gravis, there is a decremental response. In Lambert-Eaton myasthenic syndrome, there is an incremental response. So this is an example of repetitive nerve stimulation. So usually by the 5th to the 6th or midway of the test, you would see a decremental response. So here, you will notice there's a decremental response, okay, which is classic in myasthenia gravis. So here, muscle being tested is the right orbicularis oculi, and you will notice there's a decrement here. So magic number, more than 10% decrement or decrease in response. This is the single fiber EMG. Okay, this is the normal jitter on top, and below is the increased jitters. Okay, so that's what you look for on single fiber. Now, regarding the anti-acetylcholine receptor antibodies, so we have mentioned this number twice already earlier. About 85% of all myasthenic patients would have detectable anti-acetylcholine receptor antibodies. However, only about 50% would test positive for these antibodies if they have purely ocular myasthenia, wherein the weakness is confined only to the ocular muscles. Now, here's a table from our textbook. This is the disorders associated with myasthenia gravis and the recommended laboratory tests. So there are disorders of the thymus, autoimmune conditions, and the recommended laboratories like the CAT scan and the MRI of the chest to rule out a thymoma, the test for anti-nuclear antibodies, thyroid function tests, because you can also have uh, ophthalmoplegia or ophthalmopathies in thyroid disease, as well as diabetics as well. And you perform pulmonary function tests. Now, for the diagnosis of myasthenia gravis, we actually went through this in the previous table. Okay. And lastly, for the treatment. So we will utilize cholinesterase inhibitors. This would be the drug of choice. So pyridostigmine, so there's mestinon, with a dose of about 30 to 60 milligrams, 3 to 4 times a day. So since this is a cholinesterase inhibitor, you would expect parasympathetic side effects. So that would be muscarinic effects, such as diarrhea, there's abdominal cramps, and salivation. You can also add corticosteroid therapy and immunosuppressive drugs, such as azathioprine, cyclosporine, mycophenolate, and methotrexate. Azathioprine, cyclosporine, mycophenolate, and methotrexate. Now, I want you to remember this for your exams. Pyridostigmine is the most widely used anticholinesterase drug. Okay, it's the most widely used. Be careful in patients with GI conditions and be careful in patients with cardiac disease. Now, the beneficial action of oral pyridostigmine begins as early as 15 to 30 minutes. So it begins as early as 15 to 30 minutes, and it can last for about 3 to 4 hours. Now, for the other immunotherapies, so these are the drugs we mentioned earlier, and these are the drugs mentioned in the 20th edition. Mycophenolate, azathioprine, cyclosporine, tacrolimus, monoclonal antibodies like rituximab, and immunosuppressants like cyclophosphamide. Now, question, which of these drugs here would present with hemorrhagic cystitis? Which of the drugs in this slide would present with hemorrhagic cystitis? And this is because of the accumulation of the metabolite acrolein. It irritates the urinary bladder and it's notorious for causing hemorrhagic cystitis. The treatment of the hemorrhagic cystitis would be to give the drug Mesna. So the drug is cyclophosphamide. Cyclophosphamide causes hemorrhagic cystitis. Now, question, which of these drugs mentioned in the slide are calcineurin inhibitors? Which of these drugs are calcineurin inhibitors? It's cyclosporine and tacrolimus. Cyclosporine and tacrolimus are calcineurin inhibitors. Please take note of that. So let's wind down with the drugs. So mycophenolate, mofetil. This is widely used because number one, it's effective, and number two, it does not have that many side effects. This is the recommended dose mentioned in our textbook, 1 to 1.5 grams twice a day. And the basic mechanism of action of mycophenolate is to inhibit purine synthesis. So you have to be careful in patients with gout and patients taking allopurinol. Now, if there are side effects of mycophenolate, it's occasional gastrointestinal symptoms like GI upset, nausea, and rare development of leukopenia. Now, the next drug is azathioprine. Now, the catch with azathioprine is the effects are not evident right away. The beneficial effect of azathioprine can take a year or even longer before the benefits are evident. There are reported idiosyncratic reactions with azathioprine, particularly flu-like manifestations like fever and body malaise. Azathioprine can cause abnormal liver function tests, and it can also cause bone marrow suppression. So the bone marrow suppression is what you have to bring with you to the boards regarding azathioprine. Then we have the calcineurin inhibitors, which is cyclosporine and tacrolimus. Now, always remember with cyclosporine and tacrolimus, they are associated with frequent severe side effects, particularly nephrotoxicity and hypertension. So, nephrotoxicity and hypertension. That is for calcineurin inhibitors. And winding down, we have the monoclonal antibodies. There are two mentioned in your textbook, rituximab and isulizumab. Now, rituximab is what is FDA approved, and this is what we widely use. So it's a monoclonal antibody that binds particularly to the CD20 molecule on the surface of the B lymphocytes. So rituximab. Usually, when the other medications fail, there's treatment failure or lack of response, you've tried plasmapheresis, you've tried intravenous immunoglobulin, you're going to end up with these monoclonal antibodies. Now, the other treatments, which were not mentioned, would be intravenous immunoglobulin, that's IVIG, plasmapheresis, and thymectomy if there's the presence of a thymoma. So this is the last slide. This is the algorithm of the management of myasthenia gravis lifted from Harrison's Principles of Internal Medicine 20th edition. So the management of myasthenia gravis. So if it's only ocular myasthenia, then you try pyridostigmine. If it's generalized, you start pyridostigmine. You start evaluating if the functional force vital capacity, pulmonary function is good. So if it's unsatisfactory with the treatment of pyridostigmine, you did a thymectomy, you did plasmapheresis, IVIG, then you go to immunosuppression. So this is the last slide of the module. Let's mention the life-threatening condition, myasthenic crisis. So this is when ventilatory assistance and intubation is already required. So the most common cause of myasthenic crisis is an intercurrent infection, usually a respiratory infection like pneumonia. And always remember, this patient with myasthenic crisis should be treated inside the ICU. So early and effective antibiotic therapy is required, as well as ventilatory assistance and pulmonary physiotherapy. The patient should be given plasmapheresis or IVIG. So this is the last part of the module. Let me just mention this. Okay, this is the last table in your textbook. This is the drugs with interactions in myasthenia gravis. And I think this would be one of the most salient features that we should end with. Avoid these drugs in patients with myasthenia, most especially aminoglycosides, quinolones, and macrolides. Okay, very common drugs given to treat infections. Make sure your patient doesn't have myasthenia. Like in the case of aminoglycosides could cause neuromuscular blockade. We avoid beta blockers, avoid botulinum toxin, quinine, penicillamine, and please take note that we avoid non-depolarizing anesthetics like pancuronium and atracurium. Okay, so make sure you take time to read this in your textbook. So this ends our module. Thank you for listening.